why we made this dashboard. So we made it to provide insights, and we made it as a solution to provide to to hospitals firstly, and also insurance companies. So we provide this solution. It's a sold solution to those two those two like institutions or people. So we make these. We make this based on the data they provide. So if they provide the data, we can make analytical dashboards just so they can understand the data and make data-driven insights on what they can do with their data. So yeah.
So summarizing all of these.
The time is up. The
Yeah.
time is up. So, yeah, as case guys, we have to refer to the other team.
Sure. No problem.
Now it's time for questions. After the questions, we will go and have lunch break. We're suggesting that maybe lunch break can be 30 minutes, and you come back so that we finish with the rest of the teams. So yeah, the floor is open for questions. I'm gonna give you 5 minutes for questions, and then we break for lunch.
Okay.
Okay.
Sure. Any questions?
Yes. Online judges in the room. Any questions? Okay. We have a question.
Thanks again. Excellent presentation from the team. So maybe just to break it down a bit, from your understanding in the entire patient journey or the flow of money, in this case, versus the treatment protocols or regimen. So what do you understand is the role of the provider, for example? So being that healthcare provider, a doctor, and what is the role of the doctor in this case, right?
Can you kindly rephrase your question again?
So a doctor will provide that treatment protocol. So they will guide the patient or the member to follow certain steps. So if you are sick, you've got flu, you go to a doctor, and the doctor suggests whatever initial step to treat your condition, right? And then the medical aid will pay based on that. So
Yep.
the medical aid the claims will be based on what the doctor recommended. So have you had ideas of understanding how the doctor might be conflicting while the app or the technology is a powerful solution to that context, but how will it maybe be received by the doctors themselves?
Okay. How will they receive it, or how will they use this
So the
solution?
implementation, the feasibility on implementing the solution. So if a doctor gets to see this solution which best serves the patient at the core of it, which is great, but the doctor also makes money through seeing the patient coming over and over again. But at the very same time, a doctor might want to just keep to how they want to treat the patient with their clinical knowledge instead of using technology to also support that.
Yeah. Well, it's AI, so it will be basically assisting the doctor. It won't necessarily take over like the doctor's job, but it just assist the process so that healthcare like resources they don't be used. They don't have to think of a lot of treatments they could have considered. Just knowing down what treatments they could. Yeah. So it's a recommendation.
Yeah.
Classify.
Can I add to that? Okay. So I would phrase it as, on an ethical side of view, we would say the doctor can use it to prescribe the treatment that is said to work effectively for the first try. It doesn't matter if it's going to be cheaper, they're going to lose money and stuff like that. But then for the medical scheme, for them, it's going to be like a financial gain for them, because what if a patient comes and has a treatment and they know that this treatment is not going to be effective for the first try according to this app, and the likelihood of them coming back with another prescription for the same diagnosis is highly likely, then they would rather advise the patient to opt for a treatment that is ranked number one. I don't know if that answers your question.
No, yeah, so it definitely answers it. But I would also suggest that you and the first team, so SPU, maybe also ideate more how you bring the two solutions together, because I believe there's greater value in combining some of the thinking.
Sorry, can I just add also, our solution was specifically to help South African people, not the doctors, make a financial gain off our people. We're trying to help people who are less fortunate to like not pay more for, to not like waste money on things that don't work for them, essentially. That's our main objective.
Another question?
Okay.
Okay, I see a hand online from Dr. Geoffrey, yeah, if I'm correct.
Oh, thank you. Thank you very much for the presentation. Um, you showcased air quality data, PM 2.5 and PM 10 and postcodes. Let's say, for instance, I'm from Joburg. I'm coming down to Western Cape, and I got, all my family likely to catch a.
Okay, I'm following up. What is the question?
Technical team, maybe you can assist.
So, yeah, I can hear, let me just, can you, yeah, I can hear you, and then I'll just rephrase what your question is and answer it. Is that simple? Yeah. Can you continue with your question?
Okay, moving from Joburg to Cape Town, and I have a kid who likely or got a respiratory or got influenza issues. Because they have postcode data and they have air quality data, knowing the PM 2.5 and PM 10 pollution, the areas that are susceptible. Have they done special correlation in those different postcodes or areas to advise the people like us who are moving to that area? And and have they looked into modeling that, or they modeled that? That's one thing that I want to put in the easy way.
Okay, the model, like it does look into that because when we look into the data set, it uses the pollution data set. So if you look at areas like Johannesburg, there's like Cape Town specifically, it has a low air quality index. So it does look into that, and it kind of like uses that as an external like factor to like recommend the best treatment for you. I'm not sure if I answered your question or heard it correctly.
Uh, you go in there. I've done a lot of work into that. I just wanted to know from on a basic level of helping people on the ground when they have issues with flu or whatever that you guys are solving. How can you advise using the data that you have, being postcodes and knowing the particulate matters to at 2.5 and at PM10? Just in a novice way, say if you know that and you have modeled that, we either you using spatial correlation or what? What can you advise as a data person? Thank you.
Okay, I think I do get your question. I would look into, like you said, you have special data which has like a different PMTs and air quality index from different location. You could just have like a classify. This is I don't really sure if I can answer that properly.
I think it's difficult to determine because this is a limitation on our part because of the nature of the data we were given. We had to feature engineer those variables. So to identify like strong correlations would be hard right now because this is also a demo version. No, this is a beta version of our recommender system. So if we had better quality data and most, because this data we had to engineer it ourselves based on the postal code that was provided by the patient. So then, yeah, we had to have more quality data to get stronger correlations, if you understand. Because these were just feature engineered. We don't know if, even if the air quality index is correct because we had to feature engineer it. If we were provided this by the healthcare companies, we'd be able to determine. So basically, our data was not quality enough. Essentially, we had to make these features. I don't know if that answers the question.
Let me help. The data is there, for sure, because we do have an air quality management framework, and you can use a multi-level classifier based on Bayesian networks to just model that 2.5 to estimate the probability of pollutants exceeding certain threshold. But now coming to that postcode, you can look at spatial classifier also that will tell you the location on the ground where you can advise. And if someone is moving to one area to another, if you have certain illness in your family, what areas you can stay at, and so that you are avoiding the avoidable readmissions often to the hospital. That's how I would have looked at it that way. But you got the idea, you got the right data. It's just like the features were there. You didn't look at conceptualizing properly. Thank you.
Okay,
Okay. Another
I have
question.
another question. The time is over, but I'll allow two more questions and then we'll go for lunch.
So this is just a question comment hybrid. If you were to track your readmittance variable over time, bringing in a temporal component, and you see, for instance, that some of your treatments becomes less effective, would that assist perhaps in early detection of drug resistance in certain strains of influenza? That could also then help give the healthcare community a leg up on what the newest, latest superbug is going to be.
Yeah, I do agree on that. It would make the model better because it'll look into the effective date of the drug and when it was issued. So I do agree that it will better like classify the treatment based on what you said. I do agree. Yeah, you can have it.
Yeah, so I do agree with you as well. We did actually think of that, of forecasting the reoccurring treatments, reoccurring patients as well, using a time series data type, I guess. But given our large scope, at least, you could say it was a bit ambitious to have a forecasting model and a classification model, and on top of that, a user interface. Yes. Yes, sorry. So based on our data set, we lacked quite a bit. So there was quite a bit of hold as well in our data set.
One last question.
Okay, we're gonna take a last question, then we go for lunch. Any other question? Online, are you good? I still see a hand from
do.
Dr. Ditela. Are you good?
I do have one question.
Okay.
Okay, yeah. My question is, you highlighted the 26 or the 20.6% of the avoidable readmission rate, right? So I wanted to know exactly how does that actually turn or translate into actionable recommendations for healthcare providers? Is there maybe a global benchmark that you were actually comparing it with or something?
Yes, actually, we are looking into the like overall like global. I think it was 71% of the yeah from the American thing article. It was like 71% of the thing treatments are deemed to be um, avoidable. Yeah, yeah. As in the cover page, we have like a reference that we yeah. Let me just where we grounded our thing. Yeah, so we took this we took this from the 71%, and then we calculated in like South African. We basically extracted from the 71. We extracted like the South African percentage.
Okay, the time is over, guys. We have to go for lunch. And let's clap hands for Team UWC. Yeah. Yeah, so we're gonna take 30 minutes lunch and we'll come back. Please don't extend the lunch to be 5 hours. We have 3 more teams to present. The next team will be, okay, the lunch is here on like this floor, so you don't have to go downstairs. So the next team will be UMP,